Hello, my name is Laird Ruth, and I work with the Centers for Disease Control and Prevention, and I'm one of the co-authors for the study Correcting for Inflammation Changes Estimates of Iron Deficiency Among Rural Kenyan Preschool Children. I'm sitting here with Frederick Grant, the lead author on this study. So Frederick, please tell me a little bit about yourself and your co-authors.
Yeah, so my name is Frederick Grant. I did this study when I was a PhD candidate at Emory University. And the funding for this study was provided in part by International Nutrition Foundation, the Nevin Scrimshaw International Nutrition Foundation based in Boston, Massachusetts, as well as the CDC's Impact Group. The co-authors on this paper include Dr. Pamisai Dave, Dr. Rafael Flores Ayala, as well as Laird Ruth. They are from the CDC. Other co-authors include those from Emory, Dr. Usha Ramakrishna and Dr. Nyando from Emory, and Dr. Conrad Cole, who is now with Cincinnati Children's Medical Center.
Okay, so before we go into the details of this specific paper, I want to bring in the principal investigator, Parmi Sachdev. And so Parmi, please, could you give us a little background on this study?
Yeah, so the data used in the study were part of a larger study called the Nyando Integrated Child Health and Education Project, or NICHE, which CDC implemented with local institutions, including the Safewater and AIDS Project, an NGO in Western Kenya, in 2007. And the main purpose of the study was to evaluate a distribution approach that SWAP, or the Safewater AIDS Project, endorsed, which was training local women's groups with some business practices, and these women would then go door to door and sell health products to their neighbors, including sprinkles. And so sprinkles were marketed and distributed originally in 2007 in 60 villages, and we had follow-up evaluations both in 2008 and 2009. And data for this study were from the 2009 follow-up study, which included children aged 6 to 35 months who lived in these 60 villages. And at this time, we also collected extensive nutritional biomarkers, including measures of iron status and inflammation, and found it to be a unique opportunity to ask questions about the role of inflammation on iron status, especially in this area where it's rural, poor, and there's high prevalence of both iron deficiency and inflammation.
So Frederick, tell me, what was the main question you were asking in this paper?
So as the principal investigator said, this is an area with high prevalence of both inflammation and iron deficiency. So we saw it important to see if we correct for the effect of inflammation, is there any additional benefit in estimating the true prevalence of iron deficiency. So we looked at various indicators like ferritin, transferrin receptors, zinc protoporphyrin or ZP, and hemoglobin. And we looked at acute phase proteins as biomarkers of biomarkers of inflammation by measuring the CRP and then AGP. So that's what we looked at in terms of inflammation and iron deficiency.
And why did you ask this question?
Yeah, so it's important because the area where we're working on has high prevalence of both inflammation and iron deficiency, and since decades ago up to now, investigators have been trying to look at the best way of assessing iron deficiency in the population. So they've come out with 3 approaches, such as raising the cutoff point for ferritin, for instance, from the normal 12 to 15 micrograms per liter to as high as 30 to 50 micrograms per liter. And then the second approach is to remove all sample with high inflammation values using CRP or ATP and discarding the data. And then the third approach, which is very current, and what we use, the correction factor approach, that uses a mathematical approach to correct for the effect of inflammation on the iron indicator that you want to look at. So that's why I wanted to see the correction factor approach would do a very good job in truly estimating the prevalence of iron deficiency in the area where we worked.
Okay. So how do you apply the correction factor approach?
Yeah. So the correction factor approach uses a mathematical approach by grouping the sample into 4 main groups based on the acute phase proteins, CRP and AGP. And then the cutoffs for the CRP and AGP are respectively 5 micrograms per liter, and then 5 milligrams per liter, and then 1 gram per liter for CRP and AGP respectively. And then based on that, we group the children into whether they don't have any inflammation, that is normal CRP and normal AGP, whether they have inflammation that's at the beginning, that's incubation period, where the CRP is high but the normal AGP and then the early convalescence where there is both high CRP and high AGP, and then the late convalescence where there is only high AGP but normal CRP. So based on this, you calculate a correction factor using the reference as your main point, and then taking the ratio using the geometric mean concentration of the iron indicator that you're looking at by taking the ratio of the reference to the incubation, and then the reference to the early convalescence, and then the reference to the late convalescence. So now you have group-specific correction factors. And for these group-specific correction factors, you multiply each of them by the samples that have elevated CRP or AGP in each of these groups by the group-specific CRP, group-specific correction factors to get your corrected indicators or corrected values for the iron indicator that you are looking at. So from this, then you will be able to look at the effect of inflammation by comparing the corrected, when you use the corrected values to estimate the iron deficiency in the population, and then when you don't use the corrected values by just estimating iron deficiency without correcting for the effects of inflammation, and then you compare the prevalences with the corrected values or the CRP, correction factor values, and then the one that you didn't correct for any inflammation, and you see if there's any differences in terms of estimated prevalences of iron deficiency in this population.
So what were your findings?
Yeah, so what we found was that when we used the correction factor approach, we saw that it improved, I can't say it improved anyway, it increased the prevalence of iron deficiency in the area. So when you don't correct for inflammation, you are likely to underestimate the prevalence of iron deficiency when you are using ferritin as your iron indicator. When we use ferritin, we found about 27% of the children had iron deficiency. But when we corrected for the effect of inflammation, we saw that it's increased to as high as 40%. So you can see that if you don't correct for the effect of inflammation, you are more likely to underestimate the prevalence of iron deficiency when we use ferritin as our indicator. And of course, we saw that the other indicators that we use also had differences in terms of estimated prevalence of iron deficiency when we compare to the corrected values.
And what additional research do we need to explore in this field?
Yeah, it's very important because in addition to what we found that there's differences in prevalence of iron deficiency, the correction factor also unmasks the expected relationship between some iron indicators that you always expect. For example, hemoglobin and ferritin. You expect a direct relationship. As hemoglobin goes up, ferritin levels or iron standard mass also go up. And we found that if you don't correct for the effect of inflammation, you don't see this relationship. But then when we corrected the effect of inflammation, we saw this relationship appearing. So the next step for this area is to look at studies that will see if the correction factor approach was very good or the best in estimating iron deficiency prevalence in such areas. Of course, we don't know the best. The best is always looking at using bone marrow biopsies, which is very difficult to do. So now studies have to look at approaches to see if our correction factor is very good in terms of accuracy in estimating iron deficiency in such areas. So that's the next step that has to be looked at.
Thank you. That was very interesting research.
Thank you.